Good morning. This is the Health Coverage Insurance and Financial Services Committee, and we are live now this morning for a series of public hearings followed by some work sessions. And we will go in the order that is printed on our website, which would be LD 56, LD 556, LD 1036, and LD 1311 for our public hearings this morning. Christian, we haven't had any requests to the contrary, have we?
No, but I believe Representative Dorr is the only one on.
That's great. Well, we are happy to have her because her two bills are first off. But we will start this morning with committee introductions before we move into our public hearings. So I will begin with Representative Quint.
Good morning, everyone. My name is Tracy Quint. I represent House District 144, which includes Amity, Bancroft, Benedicta, Cary, Glenwood, Haynesville, Hodgson, Holton, Macwahock, Molunkus, Orient, Reed, Silver Ridge, South Aroostook, and
Thank you, Rep. Quint. And I think another couple months and you'll have that completely memorized. Okay, so next up we have Representative Connor. Please introduce yourself.
Thank you, Madam Chair. Good morning, everyone. My name is John Connor. I represent House District 58, which is part of Lewiston.
Thank you, and good morning, Representative Evans. Please introduce yourself.
Thank you, Madam Chair, and good morning, everyone. I am Richard Evans. I represent House District 120, which includes the towns of Atkinson, Brownville, Dover Foxcroft, Medford, Milo, Orneville Township, and Lakeview Plantation.
Thank you, Representative Evans. And Representative Bleier, please go ahead.
Thank you, Madam Chair. Good morning to everyone. My name is Mark Bleier. I represent District 22, which is Leamington and part of Buxton, Standish, and Limerick.
Thank you. And Representative Melorano.
Good morning. My name is Gina Melorano. I represent House District 62, which is part of Auburn.
Thank you. And Representative Brooks.
Good morning. My name is Heidi Brooks. I represent House District 61, which is part of Lewiston.
Thank you. And Representative Matheson, welcome.
Good morning. My name is Christy Matheson. I represent District 1, Kittery.
Thank you. And Representative Morris.
Yes, good morning. Thank you. My name is Representative Joshua Morris. I represent House District 75, which is Turner, Leeds, and part of Livermore.
Thank you. And Representative Morris serves as the House Republican lead on the committee. Representative Brooks, did I skip you? Representative Brooks? Well, when Representative Brooks is able to rejoin us, we'll have her introduce herself. Next is Senator Stacey Brenner.
Thank you, Madam Chair. Good morning and happy Earth Day. I represent Senate District 30, which includes the gorgeous Scarborough Marsh.
Thank you, Senator Brenner. And I am Representative Denise Tepler, the House co-chair of the committee. I represent House District number 54, which is all of the town of Topsom. And I'm looking out my window at my forsythia on this lovely Earth Day, and it is blooming. So that's nice. We are aided today quite ably by our clerk, Christian Ricci, and our wonderful analyst, Colleen McCarthy-Reed. And we will begin with LD 56, an act to prohibit insurers and third-party payers from adjusting their fee schedules for in-network providers unless the adjustments apply to all specialties. And we will invite Representative Donna Dorr into the committee to present her bill. You're still muted, Representative Dorr. Try again.
I think I'm okay now.
Yes, you are. Thank you.
Okay. Well, this is a wonderful spring morning, isn't it? I have like an inch of snow on my lawn.
Well, we are very glad to see you, Representative Dorr.
Well, it's nice to see all of you as well. Shall I begin?
Yes, please.
Okay. Good morning, Senator Sanborn, Representative Tepler, and other esteemed members of the Health Coverage, Insurance, and Financial Service Committee. I am Representative Donna Dorr, representing a portion of our capital city in House District 85. I usually say welcome to my district, but we're not doing that so far this year. I am here to present LD 56, an act to prohibit insurers and third-party payers from adjusting their fee schedules for in-network providers unless the adjustment applies to all specialties. I appreciate the opportunity to present this legislation to you today. I was approached by the Maine Chiropractic Association about the problems they were having receiving cost of living adjustments. It has been a consistent problem for the chiropractors for over the years. It's discouraging to see how other provider groups receive increases almost on a yearly basis, yet with some insurers, it has been years since the doctors of chiropractic practice have received any kind of an increase. I think there's a problem, and I think we need to address the inequities in the cost of living adjustments across the different medical practices. Thank you for the opportunity to testify in support of this bill.
Thank you, Representative Dorr. Any questions from the committee for Representative Dorr? Okay, seeing none, I will go to the first person who's on my list as registered to speak in favor of the bill, and that would be Mr. Daniel Meyerowitz of the Maine Chiropractic Association.
Good morning. Can everybody hear me?
Yes. Welcome,
Great.
Mr. Meyerowitz.
Thank you, Representative Tepler, esteemed members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Dr. Daniel Meyerowitz. I'm a resident of Holden, a lifelong resident of the state of Maine. I'm a third-generation chiropractic physician, and I am now in my 12th year of practice, and I'm currently the president of the Maine Chiropractic Association. I'll be testifying on behalf of our members and my patients strongly in favor of LD 56. So the goal of this legislation is to end the ongoing reimbursement discrimination and ensure fair cost of living increases in the healthcare market for all the small businesses in our state that focus on healthcare. We've arrived here due to continuous contractual reimbursements not keeping up with ever increasing costs of doing business. Certainly, we've all seen 10, 15, 20% even increases in insurance premiums. However, one prominent insurer has actually decreased chiropractic reimbursement by 10% since 2009, which is the year I graduated from school, consistently raising other specialty cost of living reimbursements, citing the need to increase to keep up with the costs of doing business. This cut actually followed another decrease they had done just a few years prior. And for context, since 2009, inflation as measured by the Consumer Price Index has totaled 24%. So combining that cut plus the inflationary cost of doing business, this insurer has effectively decreased our real dollar reimbursement by 27% over 12 years. Other than leaving the network, small providers have no recourse to correct this, but we must keep up with the ever increasing costs of doing business, including wage increases, insurance increases, energy increases, you name it. With a provider shortage in Maine, the last thing we need is providers leaving insurance networks, which would further reduce access to care. Now, just some context, small healthcare offices in Maine are in a really unique situation. we do not have the power to collectively bargain for antitrust laws. Large healthcare systems and facilities have bargaining power so that when they decide to actually go into an insurance contract with insurers, they can help try to force certain rates in order to get fair reimbursements. We don't have that ability whatsoever. Small offices are, again, forbidden entirely. So we must either take or leave an insurer's rates, unlike almost all other businesses that can raise prices in response to market conditions. When you're accepting an insurer's allowed amount, it does not matter what cost a business actually charges. The insurer's allowed amount is what the office is reimbursed regardless. So we're beholden to the contract, which we realistically have no means of actually negotiating for. I encourage you to vote ought to pass on LD 56, and I thank you for your time. I'm happy to answer any questions you may have on it, and we are certainly open to restructuring the bill as necessary to meet our intended goal.
Thank you, Mr. Meyerowitz. And turning to the committee, I see that Representative Evans has a question. Go ahead, Representative.
Thank you, Madam Chair. Dr. Meyerowitz, I just wanted to get an idea. Has the cuts been over the last couple of years, or are you seeing a steady stream in cuts over a 5-year time frame or whatever?
Every insurer, and thank you for the question. Every insurer is realistically unique, but I can speak to one really without naming names. What they tend to try to do, they don't usually look, and I've received letters on this, they don't usually look at the actual state of Maine per making their cuts. They tend to look at a nationwide reimbursement rate, and they say, oh, this one state's an outlier. We're going to reduce them down to more toward a national average. Whereas Maine, the cost of living in a rural state and doing business in a rural state is often more expensive than you can have in a population-based area with more people to see. So this most recent cut was in 2009, but they have sent out letters saying, you're fortunate that we haven't cut you further in the last couple of years. We have tried to work directly with insurers, but again, there's no power to collectively bargain.
Thank you.
You're welcome.
Are there any other questions from the committee? Seeing none, thank you for your testimony, Mr. Meyerowitz. And
certainly.
Next on my list is Andre Nadeau from Augusta. Please join us.
Can you hear me now?
Yes, we can, and you're welcome to turn on your video if you'd like to.
Okay, there we go. Thank you. This is definitely a new journey. Anyway, thank you very much.
Hole, we call it.
Thank you, esteemed members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Dr. Andre Nadeau, and I am a resident of Winthrop, and I'm a lifelong resident of the state of Maine. I am a former president of the Maine Chiropractic Association, and I have practiced in Augusta for 30 years. My understanding of the legislative process is often to help the little person or the little business to find a way to compete with the larger corporations, basically to find equity. Over the last several years, as Dr. Meyerowitz has already spoken of, we have lost a lot of financial coverage for chiropractic care. We continue to have the cost of living increases, the cost of doing businesses, and unfortunately, a lot of professions in the healthcare world have received increases, but not the chiropractic. We're often told that we cannot pursue this type of legislation because this is a contractual issue between the provider and the insurance company. Well, we're supposed to be able to go and negotiate for our contracts that we have. Well, in a larger hospital type setting, there are multiple doctors, there are multiple services, and they can greatly impact an insurance provider's revenue. Therefore, since they have that leverage, they are able to really negotiate contracts on reimbursement. The typical chiropractic office is quite small with a limited number of providers. And you can fully understand that even though I have a successful practice, I am too small to have any impact on an insurer's revenue. Therefore, when it comes to a contract, I have no ability to sit down and negotiate a fee schedule with the insurance companies. It's basically, as Dr. Meyerowitz also said, it's a take it or leave it situation. You either accept what we give you or you do not participate. This is where I feel that governmental input is very beneficial, because we need an ability to have conversation with the insurance companies. And this particular bill is not going to give chiropractors anything special. It's just going to put us on the same playing field or the same level, if you will, with cost of living increases that other healthcare providers receive. So with that being said, I just ask that you vote in favor of LD 56, and I thank you for your time, and I'm happy to answer any questions.
Thank you, Mr. Netto. I mean, Dr. Netto. Are any members of the committee interested in asking chiropractor Netto a question? No, thank you for your testimony. And next up, speaking in favor of the bill is Robert Reed of Lewiston.
Good morning. Can everybody hear me?
Yes.
Thank you. To the chairs and the members of the committee, to the legislative staff, my gratitude for allowing my testimony on the bill before you. My name is Robert Reed. I am the Executive Director of the Maine Chiropractic Association. My testimony today is in support of the bill before you, and I will speak to why the bill was submitted for consideration. My background is 30 years working in healthcare finance, including 13 years working for the carriers in provider contracting, provider reimbursement, provider relations. Maine insurers do not treat all healthcare provider types in a consistent manner when it comes to reimbursement. By not doing so, they are in effect choosing winners and losers in providing care to the patients. Smaller independent healthcare professionals are given individual contracts with little or no say in reimbursement, while hospital and large provider groups can annually negotiate reimbursement increases for cost of living or other adjustments. The purpose of this bill is to create that fair playing field, as you heard earlier, where all providers are given the same cost of living adjustments, ensuring we treat all providers in a fair and equitable manner. I represent chiropractic, and I can tell you at least one large carrier here in Maine, no increase for the past 12 years, and the last changes before that were a decrease in reimbursement. Any attempt to request a fee increase or a review of the fees is given a cursory, we reviewed and feel you're appropriately paid, leaving the healthcare professional to either remain in network or leave, having a detrimental effect on patient share of the cost. Keep in mind, for most of these rates were set when the state minimum wage was $7 an hour. I mentioned we employ over 1,000 additional staff statewide, all of whom have had pay increases to keep up with the minimum wage changes and the ability to pay for their own personal needs as costs of goods and services have increased because of a higher minimum wage. These independent practices pay sales and income tax to the state as private practices, and these too have increased over the past 12 years. The bill does not affect the carrier's ability to calculate reimbursement based on RVU's relative values, but will allow us to be paid equally regardless of what type of provider you are or how your contract was drafted originally. Its purpose is to simply treat all provider types equally when it comes to reimbursement. I'm happy to answer any questions you may have at this time.
Thank you very much, Mr. Reed. Senator Sanborn has a question. Go ahead.
Representative Tepler. Mr. Reed, you mentioned that you're hoping for government intervention here to regulate this area more. And so what I wanted to ask is whether you would support us as a legislature simply stating that everyone has to be reimbursed, every provider type has to be reimbursed at Medicare rate schedule or at Medicaid rate schedule. Would that work for you?
I think if there were a way to do it so everyone was treated equally, we would be in favor of that.
All right. I'm not sure it's higher than the rates that you're looking for, but.
So to give you some idea, if we were to look at reimbursement, Medicaid pays around $28 per relative value. Medicare is about $35 to $36 per relative value. I mean, that's had a couple of decreases over the past decade to meet the federal government's budget needs. Commercial insurances typically pay between $38 and $42. And then private carriers, insurance accidents, liability companies might be a little bit higher than that.
So you would be okay with us just saying every provider type is going to get reimbursed at Medicare rates, even though that would mean that every relative value unit was now $3 or $4 less than what it is today in the commercial market?
No, I would not ask you to do that. That obviously would crash the entire healthcare network in Maine. But if it was at a percentage of the Medicare reimbursement, for example, Medicaid currently pays your allowed federal reimbursement up to 70% of Medicare allowable. So if you said the carrier is at 120% of the allowable, that something like that, and I'm not sure the exact figure.
Okay. Thank you, Mr. Reed. I just wanted to point out that when government sets rates, usually the outcome is not what you want it to be. So the free market seems to have been providing higher rates for providers. So it's unusual for providers to ask us to set rates.
Thank you, Senator Sanborn. Completely understand what you're saying. We're not asking for you to set rates. We're just asking you to tell them to treat everyone equally. Maine has an anti-discrimination law in medical practices, LD 798 a few years ago, which said you need to treat everybody equally and you can't discriminate. And reimbursement is another form of discrimination against the provider.
All set, Senator Sanborn? Thank you. Are there any other questions from the committee? Yes, Representative Evans, please go ahead.
Thank you, Madam Chair. Mr. Reed, individual practitioners have to negotiate their own rates with a particular insurer as compared to organizations, hospital systems.
I would not say negotiate. What happens is when you're an individual provider, they have a standard contract, which they say, here's what we offer a chiropractor. They do the same for podiatry, optometry, and other individual providers. With a large healthcare group, say the Maine Med, PHO, Maine General, any of those, Central Maine, they come in as an entity and say, here's where we want to be for our doctors. There's give and take, and they agree upon a rate. Each year, they can also agree with an inflationary, a cost of living, or if anything else changes. We don't have that ability.
Thank you.
Okay, any other questions from the committee for Mr. Reed? Yes, Representative Matheson.
Thank you, Madam Chair. Thank you, Mr. Reed, for testifying. Could you tell me how many people are in your association? How many people do you represent, please?
We represent over 180 licensed chiropractors in the state of Maine.
Thank you.
Any other questions? Nope. Seeing none, thank you for your testimony, Mr. Reed. And next up, I will call John Royce in favor of the bill.
Can you hear me?
Yes, we can, and you're welcome to turn on your video if you'd like to.
Okay. All right, I'll just go ahead. I have very brief testimony. Senator Sanborn, Representative Tepler, members of the committee, my name is John Royce. I'm here today representing the Maine Chiropractic Association. I think that things have been explained very well. I don't think I need to restate many of the points that have already been made. But basically, what we're asking for is a level playing field. And I understand that this bill seems much more complicated than it is. We're just asking if cost of living increases are good for one provider group, then it should be good for all provider groups across the board. It's as simple as that. So I will be at the workshop. I have submitted my testimony, and I'd be happy to answer any questions you might have.
Thank you. And are there any questions from the committee?
Thank you.
Seeing none, we appreciate your brevity, and you are the last person on my list speaking in favor of the bill. Is there anyone else among the attendees who would like to speak in favor of the bill? Seeing none, I have a list of several people speaking in opposition. And first up, I'll invite Ms. Ossenfort from Anthem Blue Cross Blue Shield to speak in opposition. Ms. Ossenfort.
Thank you, Representative Tepler, Senator Sanborn, members of the Health Coverage and Insurance and Financial Services Committee. My name is Christine Ossenfort. I'm the Director of Government Relations for Anthem Blue Cross and Blue Shield in South Portland, and I appear before you this morning to testify in opposition to LD 56. Essentially, LD 56 would require that all providers receive the same reimbursement. It's not clear to me if that's what's intended, but that's how the language before you has been drafted. We would not be able to make a change to a reimbursement rate or fee schedule unless we made it for all participating providers. Clearly, that would increase premiums, and it would require all providers to receive the same reimbursement despite differences in training, scope of practice, market requirements. It's not really clear what's intended by the last sentence with respect to cost of living adjustments. From the testimony of the proponents, it sounds like they might be looking for, I don't know if it's an automatic or if there's an increase to one, there has to be an increase at all. So we're not quite sure what is understood by that. I would also suggest that if we're going to have equitable treatment, then there are several mandates on the book. There are mandates on the books with respect to chiropractic services that do not apply to other types of providers or specialists. So if there's going to be consistency, there should be consistency across the board, and the committee should consider whether those mandates should be retained. We would note that the Affordable Care Act does have provider non-discrimination provisions, but in the FAQs around those requirements, the three agencies, the Department of Labor, the Department of Health and Human Services, and the Treasury Department have specifically stated that it does not require equity in reimbursement. Finally, as Senator Sanborn noted, well, we would love the idea of paying main care and Medicare reimbursement rates, but I suspect that that's not workable. But passage of this proposal would likely necessitate reductions in other rates in order to manage costs, which will then lead to network adequacy issues as those providers seek to leave our network. And depending on the type of specialty, if there's a shortage, then their reimbursement rates sometimes out of necessity are higher. So for example, neurologists, dermatologists, cardiologists would all now be reimbursed the same as physician's assistants, nurse practitioners. So with that, I'd be happy to answer any questions that you might have, and we'll attend your work session as well.
Thank you for your testimony, Ms. Austin Ford. Any questions from the committee? Seeing none, thanks again. And now we'll turn to Ms. Pelletreau. Ms. Pelletreau.
Good morning. Senator Sanborn, Representative Tepler. My name is Catherine Pelletreau. I'm speaking for the Maine Association of Health Plans today in strong opposition to this bill. I mean, we are just fundamentally in disagreement with the approach this bill takes. As Chris mentioned, it would require similar reimbursement across the universe of providers. It's not uncommon for a carrier to reimburse different rates for, say, a PA and an MD. Frankly, those contracts are often negotiated as a group. So even if an NP is or a PA is providing the service, it can sometimes be billed under the number of a physician. So the distinction is less relevant in a group contracting environment. In terms of COLA, or cost of living adjustments, some contracts do have cost of living adjustments in them. Others do not. And frankly, the whole industry is moving away from that. Because we're trying to move towards value-based care and paying for performance and not for, a fee for service type of model. So paying less for volume and more for outcomes. So under this bill, that would not be possible. So we really strongly disagree with it, and we would urge you to vote against it. Happy to take any questions. Thank you.
Thank you very much, Ms. Pelletreau, and Rep. Matheson has a question.
Thank you, Madam Chair. Thank you, Ms. Pelletreau, for testifying. Just a quick question. How do your members handle the challenge that private practitioners have for negotiating terms? It sounds like large groups can certainly negotiate their rates, and me being a private practitioner, I feel their pain. There's very little discussions on negotiating rates. So how do your members, maybe this is more a work session, but how do they negotiate their terms with chiropractors in private practices?
Mm-hmm. I think it's a great question. I'm not sure that it's just for me. It's more of a system-wide issue as healthcare is provided less and less by individual practitioners and more by larger systems. I think we have something like 85% of the physicians are now owned or employed by hospitals. So yes, of course, there's greater leverage when you are a bigger system.
Yeah, I understand that. I was just wondering how your members actually do converse with private practitioners, since you're saying there's about 15% of them that are private practitioners. How do they negotiate their rates? Could you come back and just tell me how a couple of your members do handle that?
I would be happy to ask. I will. I don't want to, throw up a false flag or anything, but that does get into some antitrust information. So those might be questions that individual carriers would need to answer and might not want to answer publicly.
Thank you.
Are there any other questions from the committee? Seeing none, thank you for your testimony, Ms. Pelletreau.
Thank you.
And moving on to, I'm sorry, I will ask if anyone else in the attendee list would like to testify in opposition to the bill. Please raise your hand. And is there anyone who is interested in testifying neither for nor against the bill? I know that the superintendent or someone from his office submitted a letter to us, but I don't know if they wanted to speak. So if Mr. Yardley or Mr. Chapa, who are both in the attendee area, would like to speak to the bill, please let us know by raising your hand, your virtual hand. Yes, Superintendent Chapa would like to join us, so please bring him in, Christian. Good morning, Superintendent. Thank you for being here.
Good morning, Representative Tepler and members of the committee. First of all, let me apologize for yesterday's technical snafu where we had 3 people working remotely and all 3 failed at one time, which was a little embarrassing, but again, I apologize and hopefully that won't happen again. I wasn't going to testify, but again, I do want to point out that as our letter said, typically, you know, the Bureau doesn't get involved with carrier fee negotiations and provider negotiations for good reason. We think that is best left to private parties, and you know, our job is to protect consumers, and we do that through network adequacy. And that's just worth noting. And I also would like to say that I agree with Chris Ossenfor that in the same manner is unclear what that means. I mean, that could be read rather broadly in the terms of the draft statute. If the committee is interested in going forward, I urge them to evaluate that language appropriately to clarify the meaning of in the same manner. With that, I'd be happy to answer any question.
Thank you, Superintendent. Any questions for the Superintendent? Seeing none, we appreciate your being here, and thanks for your testimony. Is there anyone else in the attendee list who would like to testify neither for nor against the bill? Seeing no little virtual hands go up, I will bring the hearing on LD 56 to a close. And we will move to a hearing on LD 556. And I will ask my co-chair if she'd like to take the gavel or wants me to continue.
Just need a few more minutes if you could continue the next hearing for me, Representative Tepler. Thank you.
Not a problem. Okay, so we will move to LD 556, which is also sponsored by Representative Dorr. So if we could have her join us again. Oh, she has already. Hi, Representative Dorr. Please go ahead and present your bill.
Thank you. Good morning, Senator Sanborn, Representative Tepler, and esteemed members of the Health Coverage, Insurance, and Financial Service Committees. I am still Representative Donna Dorr, representing a portion of our capital city in House District 85. I am here to present LD 556, an act regarding co-payment and co-insurance for chiropractors. This legislation is intended to address the type of practice the doctors of chiropractic actually run. They are doctors that are fully trained in diagnosis and are, in many cases, the first provider many patients seek care from. Doctors of chiropractic practice in many very rural areas of Maine, where they may be one of the only healthcare providers for miles. Insurers classify chiropractic doctors as specialists, which means they have a high level of coinsurance and copays. This can make things much more expensive for their patients. Chiropractors are more appropriately first point of entry providers than specialists, and this bill reflects that. Thank you again for the opportunity to testify in support of this bill.
Thank you, Representative Dorr. Any questions from the committee for Representative Dorr as the sponsor of an act regarding co-payment and co-insurance issues for chiropractors? Seeing none, thank you, Representative. And we'll move on to those in support of your bill. First up again, we will have Mr. Meyerowitz. Daniel, sorry.
I was just about to ask.
Daniel first and then Steve.
Good morning again. It was deja vu. Thank you, Senator Sanborn, Representative Tepler, and esteemed members of the committee. I am Dr. Daniel Meyerowitz. I am again representing Holden, lifelong resident of Maine, representing the Maine Chiropractic Association as president. Whereas the first bill you heard this morning was seeking to just ensure the same percentage increases in reimbursement to level the playing field, not the exact reimbursement changes, LD 556 is a patient-centered consumer protection bill. This bill seeks to create a level playing field in which your constituents are no longer penalized for choosing highly effective, low-cost, and drug-free forms of healthcare. This bill seeks to do what many of the self-insured plans, including the University of Maine system, have already done, which is to lower copays and coinsurances in order to open greater access to chiropractic treatment for those in need. This bill will not change how much a chiropractic physician is reimbursed, our scope of practice, or what particular services are covered. The bill only serves to expand access to a greater percentage of people in our state by correcting an imbalance in the marketplace. As you've already heard, insurance contracts with providers assign a negotiated amount for the service being rendered, along with a copay for that service. Copays are generally categorized either as primary care or specialist. Chiropractic is unique that we fall under the specialist category, despite the fact that we are exceptionally low cost per visit, but we see people more often since we are truly a hands-on profession. Specialist categories, I'm sure you can imagine, typically would be a neurologist, rheumatologist, orthopedist, specialty care where there's 1 or 2 visits, and then there's either a surgery referral or other treatment, including injections. Due to this distinction, we're now seeing copays being assigned to chiropractic services exceeding the reimbursement amount for that service. Under a certain scenario, for instance, let's say we see somebody for an office visit, it's a $50 charge, the insurance rate's $42, but the specialist copay is $50. In that situation, the patient pays the entire $42 charge because it's less than their copay. The insurer has no liability at all. This is happening far more often than you expect. Even the current state of Maine employee insurance plan has a specialist copay exceeding the insurer's allowed amount for the primary service provided by chiropractic physicians. We call this an illusion of coverage. They're covered, but there's no actual coverage. They're still paying almost the entire charge of service. Some plans have further shifted costs onto their members by separating additional services provided by chiropractors into other categories, such as a separate deductible or coinsurance for physical therapy, acupuncture, or applying those into separate categories and assigning separate copays and coinsurance. This process needs to end. As far as another unintentional benefit, Maine has been fighting hard to combat the opioid crisis. With everything happening in the last year, obviously the situation has only continued to worsen. Chiropractic physicians are portal of entry, which means we are direct access. There's no referral needed to access our doctoral level healthcare providers with the ability to fully examine, diagnose, order, and/or perform appropriate diagnostic imaging and lab tests, all without the need for drugs or surgery. Since we do not prescribe drugs, it is impossible for a patient with a chronic pain condition to develop an addiction to pain medications by utilizing our services. This has recently been observed in a 2019 study demonstrating a 90% reduction in early and long-term opiate use when a person sees a chiropractic physician as their first point of contact for low back pain. In that study, the only distinction was going to a chiropractor first, going to an allopathic doctor first. For the vast majority of the conditions that we treat, we are the only provider for that issue. We're the first and only point of contact. And as we see that, we should stop penalizing patients for seeing this type of healthcare first. The copay, we feel, should be equal to a primary care within the insurer's network. Doing this would thus relieve a significant barrier to access for the people of Maine. Patients should not be penalized for choosing a specific provider within their network. LD 556 seeks to end this discriminatory practice by promoting equality in healthcare access. I encourage you all to vote ought to pass on LD 556, and I thank you for letting me testify, and I will open to any questions at this time.
Thank you for your testimony, and I see that Senator Sanborn has a question. Go ahead, Senator Sanborn.
Thank you for being with us, Dr. Marowitz. Did you submit or were you part at all of the discussion of the rulemaking for the Clear Choice plans?
I was not that I'm aware of.
Okay, thank you.
Any other questions from the committee? Seeing none, thank you very much for your testimony. And now we'll call your brother, Steve Marowitz. Please join us and give us your testimony on this bill.
Hello, can everybody hear me?
Yes, welcome.
Wonderful. Again, Dr. Zeb Marowitz, Senator Sanborn, Representative Tepler, and honorable members of the HCIFS committee. Again, my name is Dr. Zeb Marowitz. I'm currently the Vice President of the Maine Chiropractic Association, and I'm the Director of Health Services at Cape Integrative Health. My testimony is additionally in support of LD 556. As the director of an office that employs both primary care and chiropractic in the same building, the discrepancy in reimbursement is it's quite astonishing. I've seen plans that have a $100 chiropractic copay, but a $20 copay if the same exam is performed by the primary in our office. Chiropractic staff often serve as the initial point of contact to evaluate and manage a patient's complaint. And while these are typically musculoskeletal, sometimes they're not. While we're often the appropriate provider in managing conditions ourselves, many of these patients require referrals to various medical specialties. And in that capacity, we are acting as the portal of entry provider. If many patients require services such as x-rays, MRIs, lab testing, and we perform all of those and would make the appropriate referral upon review of that information. I would only follow up with the patient if they didn't respond to that provider's plan of care or the specialist findings warrant further referral. So we're seeing a major discrepancy where that patient, if they go through me for this process versus through their primary care provider, there's a discriminatory practice in their copay for that. If I happen to be the treating provider, there's additional financial discrimination. Yeah, as my brother alluded, it's a pretty common practice for procedures that may be performed by me personally to be looped in as a physical therapy code, even though those codes are designated by the American Medical Association as non-profession specific. Those codes are then subject to an additional copay or an additional co-insurance, even though that patient only has one copay when they're seeing me as a chiropractor. We'll also additionally find out that occasionally those patients will have both a chiropractic and a physical therapy visit utilized, even though they only saw one provider. These financial restrictions, what they're really doing is they're preventing access to care. You've heard it before. When a patient can only afford to see their primary, they're more likely to end up with a medication such as an opioid prescription. Opioids are cheap, especially when they're prescribed. Our administration and the people of Maine have declared war on the opioid epidemic, and others will testify and have testified already that we are a clear evidence-based option. The science can't be ignored. We are a mandated direct access portal of entry provider in this state, yet the discrimination prevents us from serving in that capacity due to the barriers that I've already mentioned. Unfortunately, the bill, it has precedence in Maine's 127th LD 978 prevented anti-discrimination practices where insurances were not covering procedures that we performed, but if the exact same procedure was performed by a different profession and both of them are within our scope, that was occurring as well. LD 556 further protects the patients by requiring insurers to actually insure their policyholders when it comes to mandated chiropractic coverage. I ask you to please vote ought to pass, and I'm happy to answer any questions you have at this time.
Thank you very much. And I see a question from Senator Sanborn.
Hi, Dr. Marowitz. Were you involved and did you submit any comments in the rulemaking process for the Clear Choice plans?
No, Senator Sanborn, I was not. I would ask if we had any input from either our executive director or our lobbyist, John Royce, on this topic. I was not looped in on it.
Yep, I'll ask them as well. Thank you.
Thank you very much for your testimony, Dr. Meyerowitz. And next up, we will call Dr. Netto again. We see you and hear you, Dr. Netto. Welcome back.
Very good. Thank you very much. And again, thank you for the opportunity to testify again for LD 556. I'm going to keep this short and to the point. My two predecessors gave you all kinds of details. The basic is when a person purchases insurance coverage, they expect to receive some financial assistance when they are receiving some type of health care service. If one were to go to, let's say, an orthopedist, it would not be uncommon for that visit to cost up to $300. If you have a $50 copay, you pay that, but you are still receiving a financial assistance from the insurance company to cover the rest of the payment. As was alluded to earlier, it's not uncommon for a chiropractic visit to be $42. If you end up having a copay of $50, the patient is not receiving any financial assistance for the services they're covered. But yet the insurance company does not hesitate to say, oh yes, we do cover chiropractic care. Well, the patient is not receiving any financial assistance. So are they truly receiving insurance coverage for their chiropractic services? And that's the challenge that I personally have with this the most, is if you're going to say you're going to cover something, it should not all come from the patient's pocket. And the fact that we are cost effective as far as providing services, the patient should not be penalized to say, well, you need to pay this all out of pocket, but we're still going to claim to give you coverage. That's basically it in a nutshell, just to put it right to the point. If you're going to be calling to cover a service, the patient should receive financial assistance in some way for that service. If not, you shouldn't have the right to call, we provide coverage for that, because you truly don't. Thank you very much for your time, and I will answer any questions.
Thank you, Dr. Netto. Questions from the committee? Seeing none, we appreciate your testimony. And next we'll call Robert Reed. Welcome back, Mr. Reed. Oops, you were just here.
Thank you, Chair Tepler, Chair Sanborn, to the chair and the members of the committee, the legislative staff, and those in attendance. Thank you for allowing my testimony on the bill before you. Again, I'm Robert Reed. I'm the executive director of the Maine Chiropractic Association. My testimony today is in support of the bill before you. In Maine, we routinely now see healthcare provider specialist copays of $50 and in some cases $75. This past week, I was made aware of an $80 copay on a small group plan. For those providers like chiropractic whose treatment of an injured patient could require multiple visits, this could mean a significant cost to the patient over time. In many cases, the copay required exceeds the allowed or contracted charge for the services. Thus, the patient carries the entire burden of payment. When a patient gets little or no benefit from the coverage, they are for all extensive purposes considered underinsured, if not uninsured. More importantly, some carriers will charge a copay for one service in the office and then apply a copayment or a coinsurance to another service. This is particularly true in chiropractic, and I am yet to find any other type of healthcare provider who is affected by this. What that means is for chiropractic, you get a copay for a manipulation and a separate copay or coinsurance for any therapeutic treatment, which was part of the visit. All these services are done by the provider or persons under their supervision. but the second service of the therapy falls to a physical therapy benefit. This is a significant change in the policies that are being sold today. In the past, you had a chiropractic benefit, which would include a copay. That has somehow been changed in the past few years to say you have a chiropractic manipulation benefit, and anything else will fall to other services. Pretty big change to how we're treated, and it's unfortunate. We're asking the committee to end this practice, either by limiting the copay to a percentage or fee above the base for primary care copays, or to limit application of multiple copays and coinsurances when there is only one visit with one provider being billed. Doing this will help the patients obtain the full level of care they require, instead of making healthcare decisions based solely on what they can afford. Thank you for your time. I will await your questions.
Yes, Senator Sanborn, please go ahead with a question for Mr. Reed.
Thank you, Mr. Reed. So you seem to be proposing that the legislature should design the plans or redesign the plans that are offered in the small group market and the individual market, which are the only ones that we can regulate. And fortunately, we've given that authority to the Insurance Bureau and the Clear Choice Plans legislation that was passed last year. Was the Maine Chiropractic Association involved in submitting comments to the rulemaking process on the Clear Choice plans that will be offered in the next plan year?
We were not involved and we were not aware of it.
Okay, thank you.
Thank you, Mr. Reed. Any other questions from the committee? Seeing none, we will turn to John Royce to come back and testify in favor of the bill.
Okay, can you hear me all right?
Yes, thank you.
All right, Senator Sanborn, Representative Tepler, members of the committee. My name is John Royce, and I'm here representing the Maine Chiropractic Association. Most of what I wanted to say has already been said, but doctors of chiropractic are direct access providers under HMOs and other healthcare plans in Maine. In many cases, they are the first provider that a patient will access. LD 556 is intended to put into place a lower copay and coinsurance for patients that would reflect the marketplace, the realities in the marketplace. Also, you've heard that chiropractors do practice in many rural areas where there are few healthcare providers of any type, and this legislation would help encourage access in rural areas. Now, chiropractors are considered specialists, and in many cases have copays and coinsurance that virtually cancel out the benefit of having insurance for the patient. I will be at the workshop, and thank you, and I'd be happy to try to answer any questions you have.
Any questions? Yes, Senator Sanborn, go ahead.
And Mr. Royce, I assume that you know what my question is going to be about.
Yes, I do.
So
and
speak to why the Chiropractic Association did not submit comments in the rulemaking as other providers and advocates did on behalf of their associations?
I'm not aware of doing that for Clear Choice, no.
Do you have any idea why the Chiropractic Association wouldn't have submitted plans comments about plan design?
I really cannot answer that at this point. I don't think we were that aware of what was going on with Clear Choice.
Thank you for your testimony, Mr. Royce. Seeing no further questions from the committee, I will next call Karen Smalley in support of the bill.
Good morning. Can you hear me?
Yes, we can. Thank you.
Yes. Good morning, Senator Sanborn.
Representative Tepler, and honorable members of the HCIFS committee. Yes, my name is Karen Smalley. I just moved to Cape Elizabeth at the end of 2020. I work at Cape Integrative Health, but my testimony today is as a patient. I am in support of LD 556. I've recently relocated to Maine to be closer to my family. And so upon doing so, my husband and I got new insurance. We've always been Anthem Blue Cross Blue Shield policyholders, but I am really concerned with the differences in coverage for the plans in this state. My plan isn't self-funded and follows state mandates. I love my primary, but I also love my chiropractor. They are my first points of contact for most things I need. I think of them equally as my portal of entry providers, one for my muscles, body, and pain, the other for my heart, lungs, and when I'm sick. When I see my primary for my annual, I pay no fee. I also have a very low copay for any office visit I need outside of my annual, but my chiropractic visits cover very little, even though I have a $25 chiropractic copay. My last visit after insurance adjustments was $119.56, but instead of my $25 copay, Anthem said some of the stretching and exercises I did with the chiropractor to fix my low back was physical therapy, even though I never saw a physical therapist. I called later and they told me I had used up both a physical therapy and chiropractic visit for that one appointment, even though I never saw a physical therapist. And my bill never said I saw one. I was responsible for about $95 of the visit. That feels to me like my insurance is lying. The cost is okay if I need a simple fix, but sometimes it can take several visits if I do something severe to completely resolve the issue. It seems like they're punishing me to see the chiropractor rather than taking a drug. I don't understand why I have both a copay as well as coinsurances that go to a deductible for the services I need, even though my plan says I only have a copay. I get the runaround when I call in and ask about my bill, but when I call the number on my card to verify my benefits, they keep saying I have a $25 copay. This is wrong, and I think everyone on this committee should know that this is happening here in Maine. I please ask you to vote ought to pass on LD 556. Thank you so much.
Thank you, Ms. Smalley. Any questions from the committee for Ms. Smalley? Seeing none, thank you for your testimony.
Thank you.
And next up, speaking in favor of the bill, I will call Amy Gallant. Welcome, Ms. Gallant. Nice to see you.
Morning,
Little
committee. Of course, she just started fussing this very moment. Good morning, committee. My name is Amy Gallant. As some of you know, I am employed as an advocacy director for a nonprofit organization here in the state. However, today I'm before this committee as a private citizen. This is Diana Gallant. She too is a private citizen and a resident of South Portland, Maine. Now, I usually come before the legislature in a professional perspective, but there have been 2 times that the issues are so important to me that I came before as a private citizen, and both of those times are for you. The first was a couple years ago with student loans. Those of you who were on the committee learned every detail about my financial situation, and I'm going to be similarly sharing personal details today. I am a passionate advocate for chiropractic services. Some of you might know that about a decade ago, I was riding my bike on Broadway in South Portland and I was hit by a car. It hit me on the left side, it turned into me, and it was a pretty bad crash. I had a concussion, I had post-concussive syndrome for about 18 months. Thankfully, I didn't break anything, but I did have some significant musculature and skeletal issues on that side. And one of my treatments was chiropractic care. It was a challenge at that time. I looked back and my copay was $80 per session, and it was cost prohibitive for me to continue. Fast forward a decade, and I have had 2 babies in 2 years, and which is unexpected. And the best pre and postnatal care that I have received has been at Cape Integrative Health, between chiropractor and acupuncture care. When I was pregnant with my first, Audrey, who you all know, I was very uncomfortable in my body. I was very uncomfortable with the weight that I was rapidly putting on. I couldn't be as active as I was used to, and I just didn't know what to do with myself. My OB kept saying, go to chiropractor, go to chiropractor. So at 20 weeks, I went, and I cannot even tell you the relief and release that I felt after that first session. Becoming pregnant again quite quickly after the first, I called the office and said, can I schedule an appointment with Zev, to be transparent, every other week for my entire pregnancy? And they did. I went every other week. The care was and continues to be excellent. I took a little bit of time off when Diana was born, and I went right back. Similarly, last week I called and said, can I schedule out every other week for the rest of the year? And they were able to accommodate that. And the biggest change for me is that the copay is $35. I can afford $35. I can budget that. I could absolutely not afford this care if it was the $80 that I had years ago. Thank you for your time. I really appreciate your time with Diana. She's not generally speaking up, but today she had a lot to say, apparently. I'm happy to take any questions that you might have.
Thank you very much, Ms. Gallant and baby Diana. Are there any questions from the committee for Ms. Gallant? And please give a hug to both the babies for the committee.
I will.
And we appreciate your testimony.
Thank you.
Okay, that is the end of my list of those wishing to testify in favor of LD 556. And I'm turning to the attendee list to see if there is anyone else who would like to speak in favor of the bill. Please raise your electronic hand. Seeing none, I'll turn to those who are testifying in opposition to the bill, and will ask Ms. Ossenfort to join us again. Welcome back.
Thank you. Good afternoon. I'm sorry, it's still morning. It's a long day already. Good morning, Representative Tepler, Senator Sanborn, and members of the Health Coverage, Insurance, and Financial Services Committee. My name is Christine Ossenfort. I'm the Director of Government Relations for Anthem Blue Cross and Blue Shield in South Portland, and I appear before you this morning to testify in opposition to LD 556. And I just have to say, in almost like 25 years of doing this, I've never had to testify after an adorable baby before, so this is a first. LD 556 would require that chiropractic services be subject to a primary copay. We have several concerns. First of all, chiropractors are not recognized as PCPs under the insurance code. They're not authorized to serve as PCPs. They are treated as specialists, as are many other providers in the same all other providers actually in the same vein. Physical therapists are subject to the specialist copay. If LD 56 were to pass, likely adjustments would have to be made to the primary care copay to reflect the additional services, because it would increase premiums because more of the cost would be borne by the plan. LD 556 also seems to be somewhat at odds with LD 56, which would require equality in reimbursement. Some of the arguments of the proponents is that they are more cost effective and therefore should be subject to a lower copay. But if LD 56 were to pass, their reimbursement would be increased. And as as Senator Sanborn has noted with some of her questions, this is not consistent with the clear choice plan designs that have been developed by the Bureau. We would also note that these requirements would not apply to self-funded plans or the Medicare program. And with that, I'd be happy to answer any questions that you might have, and I will participate in your work session as well.
Any questions from the committee for Ms. Ossenfort? Seeing none, thank you for your testimony, and we'll invite Ms. Pelletreau to join us again. Welcome, Ms. Pelletreau.
Good morning, Senator Sanborn, Representative Tepler, members of the committee. My name is Catherine Pelletreau. I'm the Executive Director of the Maine Association of Health Plans. Chris Ossenfort covered really pretty much every issue that I was going to raise. So I will second her testimony and just make one additional observation or comment. The committee and the state has done a lot of work around primary care. The Maine Health Data Organization has looked into this in some detail. And part of their study was looking at who serves as primary care providers. Chiropractors typically are not considered primary care providers. It does go quite far beyond just MDs, but it includes PAs, it includes NPs, OBGYNs. So there are a number of different types of clinicians that are considered primary care providers, but chiropractors is not on that list. So it is absolutely true that they're charged, people are charged a specialist copay. The same way a physical therapist or an acupuncturist, other types of services are charged the same way under insurance plans. I'll stop there and just again second Chris Ossenfort's testimony. Thank you. Happy to take any questions.
Thank you, Ms. Pelletreau. Any questions from the committee? Seeing none, we appreciate your testimony. And is there anyone else? Oh, I'm sorry. Excuse me, Ms. Pelletreau, can you hang around for a second?
Sure.
Ms. Representative Arford has a question. Go ahead, Representative Arford. I'm sorry.
Yeah, thank you so much, Madam Chair. Happy Earth Day to everybody, and thank you for being with us, Ms. Pelletreau. I'm just a bit interested in this whole notion of who qualifies to be on the primary care docket. And this may not be a question that you are able to answer, but do you have any knowledge of why the chiropractic physician would not be on the primary care docket or the list?
I mean, I'll hazard a guess at that, Representative Arford, and say that, you know, from the plan's perspective, they want to recognize primary care providers who can provide the full panoply of primary care services. And a nurse practitioner or an MD or an OBGYN has the full training to be able to do that. A chiropractor is a more specialized clinician that doesn't provide the full range of primary care services.
And that's, I'm sure, well-defined in your negotiations, I'm assuming.
It's actually in the, I mean, I would refer you again to the primary care study that the Maine Health Data Organization has done, which discusses this in some detail, but it's also in the law, as Chris Ossenfort referenced.
Okay, thank you very much.
Thank you, Ms. Pelletreau. Any other questions from the committee? Seeing none, I will ask if there is anyone else in the attendee list who has not spoken previously who would like to testify in opposition to the bill. We generally, in a public hearing, do not allow people to speak a second time on an issue. But if someone would like to submit supplemental evidence to the committee, they may do so in writing through the portal up until the time of the work session. And the committee will have an opportunity to review it. So with that said, I will turn to testimony neither for nor against the bill and invite Superintendent Chapa back into the committee to give his testimony.
Good morning, Senator Sanborn, Representative Tepler, members of the committee. I am Superintendent of Insurance, Eric Chapa, and I'm here today to testify neither for nor against LD 556. I won't read the part of my testimony that just describes what the bill does, as you're already aware of that. The 127th legislature enacted a statute prohibiting insurers from discriminating against in-network chiropractors who provide services within the scope of their license. This bill appears to expand upon that concept, providing more detail on the scope of the prohibition. However, no other statute requires a specialist copay amount to be no more than that of a primary care provider. And the Bureau has not heard from consumers about the copay or coinsurance issue this bill addresses, but I certainly acknowledge not every consumer knows of our existence. The Bureau has been contacted once during the past year by a chiropractor who asserted that a carrier was denying payment for a specific CPT code because the service was not rendered by a physical therapist. Thank you. I'd be happy to answer any questions.
Are there any questions from the committee for the superintendent? Yes, Senator Sanborn, please go ahead.
Thanks. Superintendent, I just wanted to ask whether you think this legislation is at odds with the Clear Choice Plan legislation and rulemaking and implementation.
Well, certainly the Clear Choice was designed to seek input for benefit design, and we did seek input through the rulemaking process and came up with, well, we had a proposal which has since been adopted. So in that sense, yes. I mean, if that was the legislature's intent to have us being the Bureau evaluate issues such as copays and deductibles, that was the avenue for it.
Thank you, Superintendent. Any other questions from the committee? Yes, Representative Arford, please go ahead.
Yeah, thank you, Madam Chair, and thank you, Superintendent Chapa. And again, I apologize in advance if this question has been answered previously, especially in another session, which I was not part of as I am a new legislator. But was the chiropractic profession invited to participate in the rulemaking or however it worked out? Because we've asked a number of times if they were invited to participate in the Clear Choice design comment period, and the people that have testified today have said not to their knowledge. And I'm just wondering if you have any further knowledge on that.
Well, the notices did go out to our what we call a Gov delivery list, which is anyone who signs up for the website. And I will look at the website. I'll look at that list and provide feedback at the work session. But having said that, I mean, the rulemaking, we published notice of the rulemaking. We do an email blast to all interested parties who have signed up, which is a rather extensive list. So if they're on that list, they would have gotten notice, but I can't say for certain they're on the list at this time, but I will ascertain that before the work session.
Thank you.
And I guess I would also say, Representative Arford, that to some extent, it is the responsibility of professional organizations to respond to the rulemaking process.
I absolutely understand that. However, they have to have knowledge of it to respond. Correct?
Yes, but we're not going to have work session discussion now. Thank you.
Okay, thank you.
So is there anyone else in the attendee list who would like to have an opportunity to testify neither for nor against this bill? Seeing none, I will close the hearing on LD 556 And I will ask Senator Sanborn if she would like to retake the gavel for LD 1036.
I'd be happy to, and thanks for standing in for me this morning, Representative Tepler, and sharing the duties today. We'll open a hearing on LD 1036, an act to allow state employee to use a federal military health insurance program and re-enroll upon retirement in the state's group health plan. And I will call Senator Black to introduce his bill. It may get the award for the longest title so far this year.
Can you see me and hear me?
We sure can. Go ahead, Senator.
Thank you, Senator. I like that title too. Good morning, Senator Sanborn, Representative Tepler, and members of the Committee on Health Coverage, Insurance, and Financial Services. I am Senator Russell Black, and I represent Senate District 17. I am here today to present LD 1036, an act to allow a state employee to use a federal military health insurance program and re-enroll upon retirement in the state's group health plan. I was approached by a constituent who is currently a game warden and is also a member of the Maine Air National Guard to put this legislation in. The constituent had been working as a game warden since 2014, and in 2020 joined the Air National Guard. As a member of the Guard, he is offered TRICARE health insurance for him and his family, which is significantly less expensive than the state coverage. However, he learned that because of state law, if he did not participate in the state health insurance plan for at least 20 years, he would not be eligible for the state to cover 100% of his insurance upon retirement. The intent of this legislation is allow a person who qualifies for health insurance coverage through a federal military health insurance program to decline coverage to the state plan, but still be eligible to qualify for the state benefit for health coverage upon retirement for themselves. Since putting this bill in, I've learned that there maybe needs some amendments to meet this goal, and there'll be others behind me that will talk to that, I believe. The current law is, as written, makes sense when it's applied to somebody who enters the state service later in life, so the state is not responsible for 100% of the health care for the retiree who worked only for a short number of years. However, for someone such as my constituent, it does not make sense, as they have other options through the military to provide themselves with adequate coverage, and forcing them to be on the state plan is an added cost to the state. Here's an example that was given to me by the warden. By requiring him to stay on the state plan based on the numbers currently on the state website, it costs the state $877.32 per month, $10,527.24 a year, and roughly $160,000 over the rest of his career if he retires at 47 when he is eligible. He currently also has to pay an additional $46.18 per month to keep himself on the plan. If he was allowed to participate in the TRICARE plan, as he would like to, this would be a significant saving to the state. I would have to believe that there are other state employees who fall in the same situation and may want to be on the military plan, but stay in the state plan to receive the retirement benefit. I would encourage the committee to move forward with this legislation. Thank you. And I'd be happy to try to answer any questions, but as I said earlier, I believe there are experts behind me that could answer it. Thank you.
Representative Evans, go ahead.
Thank you, Madam Chair. Thank you for bringing this forward. My question would be, is there a conflict with the federal statute regarding the military aspect, especially with TRICARE? That would be something I would really be concerned about.
I believe there is not, but I'm not sure of that. I think somebody else would have to answer it, but I don't believe there is.
Okay.
Okay. And I see no other questions for the senator. Next, we will hear from Jeff McCabe. I don't see him. We will next hear from Kyle Liddick.
There we go. Good morning. Can you hear me?
Yes.
Senator Sanborn, Representative Tepler, and members of the committee. My name is Kyle Hladek, and as Senator Black introduced me, I'm currently an employee of the Maine Warden Service and a member of the Maine Air National Guard. And I'm testifying on behalf of the Maine State Law Enforcement Association in support of this bill. So I'll just, Senator Black already explained my situation a little bit, and I can just expound a little further on that, answer any further questions. But I'm a game warden. I've been a state employee since 2014. I was previously an active duty Marine, and I re-enlisted in the Maine Air National Guard a couple of years ago. A big benefit that comes with that is the access to TRICARE benefits, myself and my family, which is significantly cheaper than the state employee health plan and offers significantly increased benefits as well. So my intention was to disenroll myself and my family from the state employee plan and enroll in TRICARE. Upon going through that process with the state HR, I learned that if I did not participate for at least 20 years of my career in the state health insurance plan, I would not be covered at 100% in retirement in regards to health insurance. That's a valuable retirement benefit worth almost $1,000 a month. So basically what I found is I'm required to participate in the state health insurance plan for the rest of my career in order to meet the 20-year participation requirement in Title V, Section 285. So as a result, I moved my family to the TRICARE plan to take advantage of the savings and increased benefits, but I've remained on the state health insurance myself. It isn't extremely costly for me to do that. It's only about $50 a month for me to stay on it. And I've chosen to do that so I'd have my healthcare covered at 100% in retirement. However, as Senator Black mentioned, it's a pretty significant portion or a premium that the state pays for me as an employee to be on the health insurance. It's about almost $900 a month, and like you said, almost $11,000 a year. So this bill would save me a relatively small amount of money, but I believe it could save the state a significant amount of money by allowing myself and others in similar situations to choose to not use the state employee health insurance if we have another alternative. So it would allow us to have access to this valuable retirement benefit without imposing that requirement that we participate in the state health insurance plan throughout our career. So it would change the requirements of Title 12, 285, specifically it's paragraph 7I, where it lists that requirement that state employees participate for that number of years, a certain number of years to get a certain amount covered. And it would allow state employees like myself who serve our state and country in the military to take advantage of the cost savings of military provided health insurance without state health insurance benefits being reduced in retirement. I'd be happy to answer any questions.
Thank you for being with us and for bringing us this issue. Are there any questions? All right, seeing none, thank you for joining us. And now I do see Jeff McCabe, so we'll bring him in. Good morning, Mr. McCabe, go ahead.
Good morning. That moment of teleporting from the waiting room into the committee hearing is always an exciting time. Senator Sanborn, Representative Tepler, members of the Joint Standing Committee on Health Coverage Insurance and Financial Services. My name is Jeff McCabe. I am the Director of Politics and Legislation for the Maine Service Employees Association. We represent, we're a labor union representing over 13,000 workers and retirees here in this state. It's not often that we come before this committee to bring bills, but when we do, it's to seek clarity and to have statute change to provide access to an earned benefit for those folks that we represent. I will mention that the changes to benefits associated with health insurance and retirement for those folks in state service are mostly statutorily in nature rather than part of the collective bargaining process, which is a question we get frequently. So I just wanted to clarify that. We're here in strong support today. You heard from the previous speaker of just one situation. This is a situation that we hear about more often than you may anticipate. And often it's after somebody has actually made this elective change and is looking to retire and didn't really have all the full information when making the decision. So as I said, we're in support of this. And, I've never fully understood why, for the purposes of eligibility, that retiree health insurance requirement is based on the employee's years, why it's not based on the employee's years of service, but rather requires the employee to participate in the health plan for a certain period of time as a determining factor. I think, as you heard, this is an issue of possibly saving individuals as well as the state money. And this is something that, I think can be achieved through the statute change. I am also, cognizant that there may be federal statute associated with this. And I think that's something that the committee can look into, get some clarification from the state as well. But it appears we should be trying to make things as simple as possible and most cost effective for all. This issue can appear complicated, and interpretation of statutes can cause unintended effects for participants, especially in healthcare coverage. This bill seems to provide a simple fix, and simply referring to the bill summary may be the easiest way to sort of think of this problem as you look toward finding a solution for these folks. Therefore, I strongly urge the committee's support. I'm happy to take any questions, and I'm also willing to provide information for the work session.
Thank you, Mr. McCabe. Are there any questions for Mr. McCabe? All right, seeing none, we'll hear from Chad Robertson. Good afternoon, Mr. Robinson. If you can unmute yourself and activate your video, we will hear from you now. There you are.
Thank you.
Go ahead.
Senator Sanborn, Representative Tepler, and members of the Health Coverage Insurance and Financial Services Committee. My name is Chad Robertson, Maine Game Warden and a member of the Maine Air National Guard. I'm here today to testify on behalf of the Maine State Law Enforcement Association in support of LD 1036. I'd like to take this opportunity to explain how the passing of this bill would be beneficial for the state and those serving in the military currently. I've served as a Maine Game Warden and participated in the State Employee Health Plan since 2013. I previously served in the Maine Army National Guard from 2008 to 2014. And recently in 2020, I re-enlisted in the Maine Air National Guard. I have been and currently pay for my state health insurance. My wife works at the hospital and she paid, the hospital covers her insurance. So I do the single plan for myself. The military option for TRICARE insurance would save me money and also appears to have better coverage in the long run. When deciding to switch over to TRICARE, I was made aware of the state's requirement to receive 100% medical benefits at retirement. And like Warden Hladick had mentioned, if we do not pay the state health insurance for 20 years, we don't receive those full benefits at retirement. Doing a bit of the math, someone in my situation would save the state roughly $10,700 a year by not being on the state's insurance. There's also some possibilities of deployments coming up and trainings, and someone in my position, I would get free healthcare during that time. And at that time, I still have to pay the state to get those 20 years for the full retirement at the end. I think this bill put forward helps state employees who have chosen to serve both the state and the country. And I think it's a smart and feasible compromise for the state going forward. I appreciate the time. Thank you.
Thanks for your testimony. Are there any questions for Mr. Robertson? Representative Connor, go ahead.
Thank you, Madam Chair. Ms. Robinson, what age would you have to be to retire to continue using TRICARE for life versus the main state insurance?
So for state of Maine, for my position, we need to have 25 years retirement. We can collect medical benefits right after that. I believe in the military, you have to do your 20 years for retirement and you can't collect until you're 60. Someone in my position, I'm not sure if I'll do 20 years in the military or not. I'll have 9 at the end of this enlistment, but I may do TRICARE for 10 to 15 years, and that would still save me some money in the long run. And if I can't get those 20 years in with the state, I won't get that 100%. I hope that answers your whole question.
Thank you. I appreciate that. That's all I have, Madam Chair.
Okay, thank you. Seeing no further questions, I'll just thank Mr. Robertson and Mr. Hleidig for their service, and we'll ask if there's anyone else who wishes to testify orally on this bill. Representative Tepler, go ahead.
Thank you, Madam Chair. I just would like to make sure that for the work session, we hear from the Maine State Employees Health Plan in regards to this issue. I'm a little surprised that we don't have any commentary from them on this issue for the bill, and feel like they might want to weigh in.
Okay, thanks, Representative Tepler.
Thank you.
And seeing no hands go up of those who want to testify, I will close the hearing on this bill. And if you'll give me just a moment, we will move on to the next bill. And so the next bill that we'll hear today is LD 1311, an act regarding the State Employee Health Commission, brought to us by Representative Evans, whose camera is off. Hopefully, Representative Evans, you're still with us. Great. Go ahead.
I am here. Thank you, Madam Chairman. And I just want to say first, good morning, Senator Sanborn and Representative Tepler, and to all of my fellow colleagues on the Health Coverage, Insurance, and Financial Services Committee. As you know, I'm Representative Richard Evans, and I represent 7 communities in Piscataquis County. Today, I am here to introduce LD 1311, an act regarding the State Employee Health Commission. The State Employee Health Commission has been a leader in innovation and trends in health and wellness, not just for Maine, but for the country as well. The bill today protects the most vital part of the Commission's mission, that is to create a labor management partnership via consensus building for any actions that are taken. It is this consensus building and partnership that has allowed the Commission to be a leader in health and wellness innovation. LD 1311 preserves and strengthens the value of that partnership by providing language that clarifies the role that the Commission currently has with the Department of Administrative and Financial Services, which is in charge of administering the active and retired employees' health insurance plans, the active dental plan, living resources program, and employee wellness programs for all those members who participate, including state of Maine and ancillary employees and their families. LD 1311 also changes the language so that the commission's advisory role to the Office of Employee Health and Wellness and the Bureau of Health of Human Resources of DAFS is strengthened to a role providing counsel, and changes the administration of the state employee health insurance program and statute by DAFS from being consistent with rules adopted by the commission to actions taken and counsel provided by the commission. This language change would avoid any further ambiguity about whether an action taken or counsel given by the commission is to be followed. The bill would also put a voting procedure into statute where there currently is none, and would state that no action of the commission could occur unless the vote was unanimous. The current practice of the commission is to try to reach consensus and to ultimately reach a unanimous vote of labor and management. So this is just a clarification to formalize the current practice and avoid any further ambiguity. Finally, the bill updates the titles of positions and programs associated with the State Employee Health Commission and State Employee Health Insurance Program to their current designations. I would be happy to take any questions that you may have. However, I believe that Mr. Jonathan French will be following me and is much better qualified to answer your questions. But if you have any questions for me, I can take those now.
Thank you, Representative Evans. Are there questions for Representative Evans? All right, seeing none, I will call on Jonathan French. Good morning, Mr. French. Go ahead.
Good morning. Senator Sanborn, Representative Tepler, and members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Jonathan French. I am a member of the Maine Service Employees Association, Service Employees International Union, Local 1989, and I am currently serving as the Labor Co-Chair of the State Employee Health Commission. I am representing both my union and my caucus in support of LD 1311, as it would strengthen and clarify the role of the commission and addresses language that needs to be updated in Maine statute. The mission of the commission is to create a labor and management partnership that ensures the highest value health and wellness services are accessible to its members. However, in addition to the value that the commission provides its membership, the commission has also driven health and wellness trends in Maine and in the rest of the country through innovation. It has been nationally recognized by the Leapfrog Group, the National Alliance of Healthcare Purchaser Coalitions, and the Robert Wood Johnson Foundation, in addition to organizations in other states. The key to fulfilling this mission has been the labor and management partnership. In addition to the labor members from the various employee unions that represent plan members, the commission membership also consists of the Executive Director of Employee Health and Wellness, as well as the Director of Bureau of Human Resources, both of the Department of Administrative and Financial Services. Considering these two management members are part of the commission already, they have input into what the commission decides for action to be taken. The Director of the Bureau of Human Resources is also the management co-chair of the commission and controls the sole vote of management. However, in spite of the role that both of these positions hold in the commission only serves in an advisory role to those two positions in statute. It is also written that the administration of the health plans and programs must only be consistent with rules adopted by the State Employee Health Commission. The commission does not follow an official rulemaking process, so this part of statute is left open to interpretation. It could potentially be used to disregard an action of the commission if the action was not interpreted to be a rule. This would jeopardize both the labor management relationship and any future leadership of the commission for Maine health and wellness. To negate this risk, language in the bill would change the advisory role of the commission to one of providing counsel, which can be defined as providing a policy or plan of action or behavior. It would also change the word rules adopted to actions taken and counsel provided which would include official motions made and approved by the commission, as well as any consensus on council provided without a motion. Although the votes of both labor and management are quantified in Maine statute, voting procedure is not. Now, I've personally witnessed that the commission does its best to come to consensus and has for every official vote taken since I've been on it, but there is still the possibility, just given the voting structure, for a tie vote to occur. In the case of a tie vote, there is no current procedure for what happens. Therefore, to alleviate any future voting concerns and to clarify procedure, it's important to prioritize consensus building by adding the language, votes of the commission must be unanimous for action to be taken. With the language in this bill as provided, management would not be able to implement something contrary to the consensus that was achieved at the commission, which may not be the case now, depending on interpretation of the current language in statute. The proposed language leaves no such ambiguity. It has been an honor to serve my union and the commission and the members of the various health plans on the State Employee Health Commission. I've enjoyed working with both management and labor members to further health and wellness in Maine through innovation and by consensus. That consensus building is at the heart of the commission's mission, so it is crucial to protect its value, as it also protects the commission's value to the state of Maine and its citizens. Therefore, I strongly urge the members of the committee to accept the language changes that protect and strengthen the value of the commission, and vote ought to pass for LD 1311. Thank you, and I'm happy to answer any questions.
Thank you, Mr. French. Are there questions for Mr. French? I have a question. So
sure.
If the commission isn't able to reach a consensus, what happens? I mean, is it that the status quo remains in place? Because it's not always possible to have the status quo remain in place in an insurance kind of context. So can you speak
Correct.
a little bit to that?
We've never encountered it as far as I've been on the commission. So that's why we were, basically that we've always tried to reach that consensus and we've always been able to reach it. So we haven't encountered a procedure, but there have been past instances where there was a thought there might be a tie, and then the question is, well, what happens? And then so it's to avoid that question, we always try to reach the consensus. So this basically puts us in that we would have to reach consensus. That's what we have to do. We have to reach that to get to meet the deadlines and meet those timelines that are required to get our insurers and things the proper notice to be able to make the changes in the plans that we need to make.
So if we were to enact this bill, which requires unanimity, so in effect requires consensus, what happens if it's not reached? Does the bill address that?
To my knowledge, the bill does not at this point. But like I said, there has not been a point when we have not reached consensus, because we understand that we need consensus in order to fulfill our mission, in order to basically move forward. And we want to reach that consensus so that we have the equal say in the health plans that we administer.
Okay, thank you. Are there any other questions for Mr. French? All right, seeing none, I'll ask if anyone else wants to testify in favor of the bill. Seeing no hands go up, I will turn to those in opposition to the bill and ask Anya Trundy to join us. Good morning, Ms. Trundy, go ahead.
Good morning, thank you. Senator Sanborn, Representative Tepler, and members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. I am Anya Trundy, Director of Legislative Affairs for the Department of Administrative and Financial Services, commonly known as DAFS. I am before you today to provide testimony in opposition to LD 1311, an act regarding the State Employee Health Commission, because we sincerely don't understand why the proposed legislation is necessary. From DAF's perspective, not prospective as I've written there, the State Employee Health Commission can be held up as an example of a well-functioning labor management committee. There is little to no existing conflict between the two parties, and the group has a track record of working together in good faith to address issues as they come before the commission. DAF's two primary concerns with this bill are: one, the addition at the end of section 4, requiring that votes of the commission must be unanimous for action to be taken, and 2, the replacement of rules adopted in section 5 with actions taken and counsel provided. Additionally, DAFs has technical concerns regarding the rewording in section 2. Presently, all votes of the commission are to be cast as 1 vote by the labor co-chair representing the majority opinion of labor members and 1 vote by the management co-chair on behalf of the management members. When there is disagreement between the two parties, current practice is to stay at the table and to continue working through the parties' differences until consensus can be reached. Historically, consensus has been achievable, so this proposed change feels like a solution in search of a problem. DAFS is concerned that should this bill be passed, requiring a unanimous vote could be used as a means of obstruction in the future, which has the potential to result in missed deadlines, incurred costs, and failure to deliver services to plan members, outcomes that are unacceptable to DAFS. Replacing rules adopted with actions taken and counsel provided is a pivot away from well-established, carefully articulated regulations that receive thorough vetting through the MAPA process to a less intentionally formulated, more unpredictable guidance framework. If the SEHC wants to alter its overarching instruction to the Office of Employee Health and Wellness, DAFS would prefer it be done through rulemaking. Finally, while this bill deals with Title V, Section 285A, which established the State Employee Health Commission to serve as trustee of the group health plan and advise the executive director of the Office of Employee Health and Wellness, what you can't see in the bill text is that Title V, Section 286, assigns responsibility for the state employee health insurance program to the DAFS commissioner and charges the executive director of the Office of Employee Health and Wellness with daily operations and providing cost-effective, accessible, and responsive services to employees and retirees. The Office of Employee Health and Wellness is comprised of subject matter experts with years of experience in health insurance and benefits administration that shouldn't be discounted. They administer the state employee health insurance program and other benefits within the budget and the law. The commission is a group of individuals that all have other daily work responsibilities, mostly not in the field of health insurance and benefits administration. Additionally, the commission's membership has a significant turnover rate, and while the Office of Employee Health and Wellness takes steps to educate commission members, it is a huge learning curve for those who are not immersed in the day-to-day administration. Both changes that DAFS has expressed concerns with could give rise to situations where labor is at odds with the legislative directives DAFS has been tasked with, preventing DAFS from carrying out its responsibilities and interfering with the administration of benefits. It is DAF's opinion that the current statute establishes an appropriate balance of power and necessitates collaboration between the SEHC and DAFS and is not in need of a change. Thank you for allowing me to testify. I'm happy to answer questions, and we will be available at the work session.
You faked me out there with your ending, Ms. Trundy.
I had to roll.
All right. Are there any questions for Ms. Trundy? All right, seeing none, thank you for joining us today and explaining DAF's position. I see no other folks signed up to testify on this bill. So if you did wish to testify on this bill, please raise your electronic hand at this time. Seeing none, I'll close the hearing on LD 1311. And we do have a couple of work sessions, scheduled for today. It is a light day, and that was intentional. Because we have a Senate confirmation session this evening. So the senators are going to be traveling this afternoon in the Augusta direction. And so I think with that, why doesn't the committee take about a 45-minute lunch break? And we can reconvene for work sessions at 12:45 if that works for everybody. Certainly give me a wave if you need more time than that. All right, seeing none, are there any announcements?
I will send Oops, sorry. Yes. Thank you, Madam Chair. I will send the link right away via Google Meets.
Yep, and I'll send out our link as well. Colleen, go ahead.
Yeah, I just have one additional language review that I could do really quickly on a bill after your work session is over. So I'll
Perfect.
send that out shortly.
Great, thanks, Colleen. All right, anything else? All right, we'll see you at 12:45. Thanks, everybody. Yes. Okay, hello everyone. And welcome back. Just bear with me for a moment while I sort out where we are here. Okay. So we do have a couple of work sessions scheduled for this afternoon, and we're going to start with LD 504, which is a resolve regarding certification of certain mental health rehabilitation technicians. And Colleen, I'm going to have you present your analysis.
Sure. Share my screen now. I think everybody can see that. Is that big enough? I'm going to hide the tools pane. So LD 504, this was a work session we had previously scheduled, but we postponed it until today. So we haven't had a chance to talk about this bill, although you did receive the bill analysis previously. As Senator Sanborn said, the bill is a resolve. It comes out of a recommendation from the Working Group on Mental Health, which was put together at the end of the 128th legislature. As drafted, the resolve would direct the Department of Health and Human Services to amend its guidelines no later than October 1 of 2021 for the mental health rehabilitation technician community certification, also known as MHRT/C certification, in order to allow an individual who's completed a 4-year post-secondary degree program or obtained a graduate degree in a mental health related field to receive that certification, notwithstanding any other guidelines for certification. And the link to the testimony is provided. And as we heard at the public hearing, these certified mental health rehabilitation technicians provide community support services to adults living with mental health, with mental illness. These services include community services, case management services, assertive community treatment, skills development, day support, and family psychoeducation. The position and certification is unique to Maine, and there's only one way to obtain the certification. As you heard at the public hearing, currently that's through demonstrating competency in 8 different knowledge domains and taking an additional course specific to Maine's mental health system. As you heard at the public hearing, currently the certification is provided through a contract with the Department of Health and Human Services, and the University of Maine System's Muskie School Center for Learning provides the certification. The Department of Health and Human Services, their Office of Behavioral Health, did provide some additional written information to you that further describes the certification program. As I mentioned, this resolve comes from a recommendation of the Working Group in Mental Health, and I also provided a link to their report. The testimony from proponents noted that these changes would reduce the barriers to certification for qualified individuals with bachelor's degrees and help address workforce shortages. The same barriers and certifications do not exist for those working to deliver children's mental health services, and the certification pathway would still remain available to others seeking employment in this field. So the training and certification process would be available to others. What this resolve does is it just would provide that those who have bachelor's degrees in related fields could receive the certification without having to go through the specific training and certification program. You did have some testimony from the University of Maine System on behalf of the Muskie School. Their position was that changes in the certification requirements would not be necessary, as there are already multiple academic and non-academic pathways to achieve the certification, and that relevant work experience in adult mental health can be considered as part of an application for certification. Their testimony also noted that there have been efforts made recently and will continue to be made to appropriately streamline the certification and recertification process. They raised some concerns that a blanket allowance of mental health related degree programs that did not cover the essential competencies that's part of and standards that's part of the certification program could reduce the quality of care and services delivered to those adults with mental illness. In response to some questions from the committee, Ms. Warren did follow up with some additional information from the Muskie School about the certification program and the length of time needed to complete the certification. So that's linked here. And then I also emailed that again to you this morning. I'm happy to go over that, but I also know you have some folks here in the room who can answer some further questions about that. I also know you had additional information that you received by email from Ms. Shaughnessy on behalf of the Alliance of Mental Health Providers. And then the last thing I would mention quickly here is that the fiscal information preliminarily from the Department of Health and Human Services indicates that any additional costs are expected to be minor and can be absorbed within their existing budgeted resources if the resolve moves forward. I'll stop sharing. I'm happy to answer any questions. And as I mentioned, I know you have a couple of folks in the room who could answer some questions if you have further inquiries. Thanks.
Okay, are there questions from the committee or discussion from the committee about this bill? Representative Matheson, go ahead.
Thank you, Madam Chair. I just wanted to indicate that I do support this bill moving forward.
Thank you, Representative Matheson. Representative Quint.
Sorry, thank you. I support this bill. I do still have a concern when it comes to the accreditation because they're comparing like adults and children together. And when an adult is in the mental health crisis, they're much larger and more able to do more damage to those around them if they do not have the proper training. And going through, I didn't see that there was still specific language regarding. I don't know if I'm overthinking this. I really don't want to because I do understand the shortages, but I work in this field frequently and have been involved in people in crisis. And a new graduate coming out with a baccalaureate may not be prepared to deal with a crisis like this if they have not had that additional training that I see that this certification is. And so is there anybody that can answer that question for me? Is there some sort of training that they're taking, that they're getting signed off on, that is allowing them to deal with a crisis situation with safety? And I'm not talking about just and I don't mean to say just a human services degree, but something additional for dealing with a crisis of this. Thank you.
Thanks, Representative Quint. I guess I would ask Mallory Shaughnessy to join us because I think she would be the best prepared of the folks that have joined us, I think, to answer that question. Good afternoon, Ms. Shaughnessy.
Hello, hi. And I have to say, I'm just leaving another meeting that was happening. And so I missed the point that you wanted me to speak to.
Okay, so I'll try and summarize. I think Representative Quint was concerned, she's supportive of the bill, but was concerned that if we removed the certification requirement, that folks might be unprepared to deal with adults who are quite large in their physical stature, who might be in a mental health crisis. So can you speak to that issue and how that training is provided?
Oh, yes. Before anybody begins their work, when they come on board in an agency, they are going to go through some initial just basic training around crisis resolution and how to address somebody in that type of a situation, how to de-escalate. All of that is just common, regular training anybody coming on to work with people is going to go through with an agency. So that's not even part of the MERT process of certification. So that's something that is inherent in the programs. themselves before they can see clients and work with them. So it's not even part of the competencies of the MERT. Is not, there's no, hands-on training about crisis resolution or any of that. De-escalation, that's not part of their training. It's inherent to the agency's training.
Representative Quint, go ahead.
So if I may, I know with some facilities, they have like the CDS trainings where they're actually where they take the training, they sign off, they can show that they've dealt with that situation. Are you saying that these organizations that would fall under this have that same sort of requirement, that they're actually having a consistent sort of training and dealing with this issue?
Yes, they have to, with their licensing and with the work that they do, they have to provide sort of the hands-on training for staff before they can really be working with people. Yeah.
Great. Thank you for answering those questions for us, Ms. Shaughnessy. Are there any additional questions for Ms. Shaughnessy? All right, seeing none, we thank you for joining our meeting this afternoon. And I think at this point I would entertain a motion if anyone has one. Representative Matheson, I saw your hand. Go ahead.
I make a motion to ought to pass.
And I'll second it.
Okay. Colleen, does this need to be amended in any way?
I don't think the language itself has to be amended, but as I noted and as I'm thinking about it, if the resolve as drafted requires that the guidelines be amended no later than October 1 of 2021. So the committee might consider, because of the timing, especially if it might be a resolve that receives unanimous support of the committee, adding an emergency preamble. That's the only thing I might throw out there, if that's something you would be interested in doing. That way, if it is enacted, it will go into effect immediately, and then DHHS could begin the process and be ready to meet that October 1 deadline.
Okay. Is everybody okay with it being in the emergency? Okay, great. Representative Matheson is nodding her assent as the mover, and Representative Arford as the seconder. So I think we're good. And is there any further discussion on the motion ought to pass as amended? All right, seeing none, I'll ask the clerk to call the roll.
Representative Quint.
Yes.
Representative Quint, yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Blyer.
Yes.
Representative Blyer, yes. Representative Morris.
Yes.
Representative Morris, yes. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Evans.
Yes.
Representative Evans, yes. Representative Arford.
Yes.
Representative Arford, yes. Representative Millerano.
Yes.
Representative Millerano, yes. Representative Brooks.
Yes.
Representative Brooks, yes. Senator Stewart. Senator Stewart is absent. Senator Brenner.
Yes.
Senator Brenner, yes. Representative Tepler.
Yes.
Representative Tepler, yes. Senator Sanborn.
Yes.
Senator Sanborn, yes. That's 12 yes, 1 absent.
Okay. Next, we will turn to LD 945. And I think it'll be helpful to have Colleen go through her analysis on this as well.
Okay. I'm going to share LD 945 as well. This is a bill Representative Morris sponsored. It's an act regarding notice by health insurance carriers of policy changes. As drafted, the bill would provide that the notice insurance carriers must give to healthcare providers in order to change a material term of the contract during the contract year must be in writing and be the only subject of the written communication. Current law does require carriers to notify participating providers of a proposed amendment to their provider agreement at least 60 days prior to the amendment's proposed effective date. If an amendment that has substantial impact on the rights and obligations of providers is made to a manual, policy, or procedure document referenced in the provider contract, such as material changes to fee schedules or material changes to procedural coding rules, the carrier shall also provide 60 days notice. The statute does require that a carrier and a provider may mutually waive that 60-day notice requirement. So as I mentioned, LD 945 would amend that current law provision to specify that notice provided by carriers of any changes or amendments must be a separate discrete notice and be provided in writing. Current law doesn't currently specify how the notice is provided. And you did have testimony at the public hearing related to the different ways that carriers comply with the statute. Some send monthly or quarterly communications, some communicate more frequently, and notices do often include several changes. Proponents of the bill seek to have a uniform, sort of consistent way of communicating these changes by carriers, since there's no uniform manner used by carriers now. They may use electronic newsletters, and changes may be embedded in those newsletters and missed. Providers indicated that the current process is time consuming and believe this proposal may help improve their claims processing. We did have some suggestions from proponents of the bill that the committee consider amending to require that the notices be sent by certified mail, return receipt requested. Although you probably should be aware that that would add additional administrative costs to the carriers for that additional sort of mailing costs associated with certified mail. A couple of other questions that were raised was whether notice was required to each individual provider. Could the notice be provided to each specific contracted entity? The language as needed may, as written, may need some additional clarification. And I would note that it also sort of is subsequent to the work session, some suggestion was made that maybe the committee might clarify that the language would continue to allow sort of electronic communications by carriers, but maybe modify the language such that if the email communication is used, that it be separately noticed or separate attachment provided, so that sort of the appropriate level of attention is drawn to those changes to the provider contracts. We don't yet have any fiscal information on the proposal, and I will stop there, and I'm happy to answer any questions.
Are there questions or comments? Representative Morris.
Yes, thank you, Madam Chair. As Colleen pointed out, this was my bill. I have been talking with both sides, and I think we've got something that they can live with, though may not be completely happy with. And this came to me from the Hospital Association this morning as an amendment that the notice required by the subject section must be provided in writing to each provider, and the notice must be the only subject of the written communication. The communication may be included as an attachment to an email as long as the subject of the email indicates that a policy change is attached.
Is that a motion, Representative Morris?
Yes, that's the motion. I'll have to pass this amended, that language, yes.
Great.
Sorry.
I saw a second from Representative Quint. And is there any discussion on the motion? All right. Seeing none, the clerk will call the roll.
Representative Quint.
Yes.
Representative Quint, yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Blyer.
Yes.
Representative Blyer, yes. Representative Morris.
Yes.
Representative Morris, yes. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Evans.
Yes.
Representative Evans, yes. Representative Arford.
Yes.
Representative Arford, yes. Representative Melarano.
Yes.
Representative Melarano, yes. Representative Brooks.
Yes.
Representative Brooks, yes. Senator Stewart. Senator Stewart is absent. Senator Brenner.
Yes.
Senator Brenner, yes. Representative Tepler.
Yes.
Representative Tepler, yes. Senator Sanborn.
Yes.
Senator Sanborn, yes. That's 12 yes, 1 absent.
Okay. Colleen, you have some language review for us?
I do. I just have one language review. I'll do it quickly. I did have a chance to email it out during your break. But this is LD 790, and you previously had looked at this amendment, which is to add an emergency preamble to the bill. This was the bill that would clarify the provision related to patient consent for certain medical examinations. So you'd already previously looked at the emergency preamble and approved that language. We didn't yet have the fiscal impact, no fiscal impact. So I just wanted to make you aware of that before we can go ahead and report the bill out to the House and Senate.
Great.
So that was it.
That was easy.
Yep.
Okay. Does anyone have any other announcements? And as we close out our day, it's nice to be done a little bit early today. I want to get a chance to go to the gym. I'm very excited about it.
Yeah.
Anybody else? All
Stay
right.
safe, Senators, stay safe.
All right.
Yeah.
Yeah.
Enjoy Earth Day, everybody. The rest of it.
Yeah. Happy Earth Day. Don't blow
Ice
away.
cream, ice cream.
Okay. Bye.